Good evening, everyone. Welcome to this webinar entitled Diagnostic Ultrasound of the Wrist and Hand, presented by Dr. Troy Henning. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to identify the 6 dorsal compartments of the wrist, recognize the median nerve and ulnar neurovascular structure, and list the sonographic findings associated with trigger finger and thumb. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Troy Henning and Darcy Belito de Luna have no disclosures. At the conclusion of this webinar, you will be able to access the CME test located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Dr. Troy Henning.
All right. Good evening or good afternoon, depending where you are in the country. I would first like to thank Darcy for helping me with the webinar. I'd also like to thank Dr. Hall and Dr. Hoffman, as well as all the organizations involved, for inviting me to give this presentation. I have nothing to disclose. A preview for the talk tonight will start going over the dorsal wrist and hand, and then move on to the volar wrist and hand. Throughout the presentation, we'll discuss potential ultrasound-guided procedures for each area. Along the dorsal wrist, we'll talk about the joint recesses and some of the hand joints, some of the ligaments you might want to look at, the dorsal compartment tendons, as well as briefly touch on the superficial radial nerve. As we know, the wrist is comprised of 3 separate joints: the radiocarpal joint, the midcarpal joint, as well as the distal radial ulnar joint. Normally, these are non-communicating joints and only communicate if there is ligamentous or capsular disruption. Sonographically, we can see the dorsal aspect of the wrist. Normally, these recesses can be closed. Sometimes you may see a small fusion. You may also see thickening of the capsule, and if you were to turn on Doppler, you may see increased Doppler signal signifying synovitis. The distal radial ulnar joint, pictured here in the bottom left, is best imaged with the transducer axial to the wrist or forearm. Here you see the ulna and the radius with the dorsal aspect of the recess here. On occasion, you may also see ganglion cysts along the dorsum of the wrist, as is the most common location for a ganglion cyst. Usually these emanate from the scapholunate interval, where there will be a hole or tear in the ligament and capsular structure. Normally, the scapholunate ligament, which we'll touch on later, would have a nice compact fibular pattern without the fluid leaking out between the 2 bones. The dorsal recesses can be easily accessed for interventions such as injection or aspiration. Normally, I find it's easiest to approach it from a distal to proximal direction in plane with the transducer. The needle can be easily visualized coming down through the subcutaneous tissue into one of the target recesses. You would have to find a window between the overlying tendons, however. The The distal radial ulnar joint can also be easily accessed from the dorsal aspect of the wrist. Normally we'd use a gel standoff. Here you see gel heaped up over top of the dorsum of the wrist. The needle is then brought in through the gel, through the back of the wrist, into the dorsal aspect of the distal radial ulnar joint, immediately deep to the extensor digiti minimi tendon. The hand joints, while they're more commonly assessed using radiographic imaging as depicted here, can be visualized on ultrasound, where you may see joint effusions, subluxation or displacement of the bones, as well as osteophytes. Ultrasound is more commonly used for interventions where we would target the joints for injections. The CMC joint or the STT joint can be approached usually from a dorsal to volar direction. The left image here is out of plane injection relative to the joint, but in plane with the transducer. This picture down here shows the location of the transducer. The red arrow would signify the direction of the needle moving from a dorsal to volar direction. Again, using a gel standoff window, the needle is brought in through the gel, into the skin, and then down into the joint. Once the tip is located within the joint, the injection or aspiration can occur. The out-of-plane approach is done with the transducer along the long axis of the thumb. The needle again is brought in from the dorsal aspect, short axis to the transducer in this case, where you'd look for an echogenic dot within the center of the joint. Finger joints such as the MCP or IP joints can be approached similarly. Again, more commonly assessed radiographically. Usually the injection, ultrasound-guided injection would be the more common reason to assess these joints. I find the out-of-plane approach, as discussed previously, is the most easiest way to inject these joints. The transducer is placed along the long axis of the finger, overlying the joint. The needle can then be brought in either from an ulnar to radial or radial to ulnar direction, depending on your preference. The needle would then be seen within the joint recess before the aspiration or injection would take place. Moving on to the dorsal ligaments, we commonly look at the scapholunate and lunotriquetral ligaments. If we look at the radiographic image depicted here in the bottom center, you'll see the scaphoid and lunate are roughly just distal to the radius and along the same axial plane. The transducer would then be placed over the dorsum of the radius axial relative to the forearm and then translated or slid distally until you see the scaphoid and lunate bones. Between them, you'd look for the compact fibular structure delineating the scapholunate ligament. Going back to the radiographic image, you'll notice that the lunate and triquetrum here are slightly oblique relative to the forearm. Therefore, the transducer would need to be placed oblique as well to the forearm in order to adequately visualize this compact fibular structure connecting the dorsal aspect of the lunate and triquetrum. The thumb is another common area where we would assess the ligament, specifically the ulnar collateral ligament of the thumb. As we know, this connects on the ulnar side of the thumb at the level of the MCP joint connecting the metacarpal and the base of the proximal phalanx. Again, normally it would have a compact fibular structure. This ligament can be injured acutely, such as with skier's thumb, or chronically through a lot of tension over time, such as with gamekeeper's thumb. Typically, the ligament would be injured from its distal or insertion area along the base of the proximal phalanx, either involving solely the ligament or perhaps pulling off a chunk of bone with an avulsion fracture. The ligament may remain in place or, as depicted in this bottom left image, retract proximally and fold over on itself, creating the so-called Stenner lesion. A Stenner lesion would be a surgical indication, as the overlying adductor aponeurosis would fall down in the hole created by the void of the ulnar collateral ligament, not allowing it to flip back over on itself and scar in place. The ulnar collateral ligament can be easily visualized dynamically on ultrasound, either with deflecting the thumb with the transducer or using your opposing hand, looking for the integrity of the ligament. You could compare side to side to see if there's excess of displacement on the symptomatic side versus the asymptomatic side. Additionally, to help delineate the location of the adductor aponeurosis, you can dynamically move the aponeurosis. Here we see the metacarpal and the proximal phalanx with the ulnar collateral ligament connecting the two bones. This relative hypoechoic structure here is the adductor aponeurosis. The aponeurosis itself connects dorsally into the extensor pollicis longus tendon. We can therefore use the excursion of the extensor pollicis longus tendon by deflecting the IP joint of the thumb to move the aponeurosis back and forth, making it more conspicuous or easier to see overlying the ulnar collateral ligament. Moving on to the dorsal compartments of the wrist, you'll see that they are conveniently housed in a fiber osseous tunnel about the distal forearm. Starting on the most radial aspect, you have the first compartment, which is composed of the adductor pollicis longus and extensor pollicis brevis. The second compartment is the extensor carpi radialis longus and brevis. The third, which is separated from the second by a protrusion or bump along the dorsum of the radius called Lister's tubercle, is the third compartment, which is extensor pollicis longus. The fourth would be more ulnar. It houses the extensor digitorum communis as well as extensor indicis proprius. This diagram here is not necessarily that accurate. Normally the extensor digitorum communis is situated above the extensor indicis proprius. The fifth compartment, or extensor digiti minimi or quinti, overlies the distal radial ulnar joint. And then lastly, the sixth compartment, or extensor carpi ulnaris, overlies the dorsal ulnar aspect of the ulna in a little fossa or fovea on the side of the ulna. Clinically, the first and sixth compartments are most problematic. Here are some videos showing how to evaluate each of these compartments. Again, normally the transducer will be situated axial relative to the dorsum of the forearm, and then placed over top of the compartment that you're attempting to interrogate. Here we would move the transducer all the way to the to the radial side of the forearm to look at the first dorsal compartment. Again, that houses the adductor pollicis longus and extensor pollicis brevis tendons. The right of the screen here is radial, left would be ulnar. This is the adductor pollicis longus and extensor pollicis brevis tendon adjacent to one another, overlying the radial styloid process here. Sometimes it's hard to differentiate the tendons from one another, and so you have to sometimes pull the transducer a little bit more distal than the radius to delineate the two tendons. So here you see the larger tendon being the adductor pollicis longus, and the smaller tendon being the extensor pollicis brevis. The second compartment is composed again of the extensor carpi radialis longus and brevis. They insert into the base of the second and third metacarpal respectively. Here is the longus, and this one is the brevis. So extensor carpi radialis longus and extensor carpi radialis brevis. The third compartment is the extensor pollicis longus. Again, this is just ulnar to the dorsal protuberance of the radius called Lister's tubercle. So that's a nice bony landmark that is always present. You can sometimes palpate it, and you should always see it sonographically. You'll notice that the extensor pollicis longus will move from an ulnar to a relative radial direction as I move from the wrist or the dorsal radius into the hand. It's fairly small and sometimes hard to see as it crosses down into the hand. It would then go all the way down to the base of the distal phalanx of the thumb. Importantly here, you'll also note that it's crossing over the second compartment tendons, which we will talk about in the near future. The fourth compartment is comprised of the extensor digitorum communis and the extensor indicis proprius. Again, the extensor digitorum communis overlies the extensor indicis proprius. As the video plays, you can see the extensor indicis proprius and extensor digitorum communis here as they separate from one another. Again, the EDC, or extensor digitorum communis, overlies the proprius. The proprius along the dorsum of the hand would be more ulnar relative to its extensor digitorum counterpart. The fifth compartment overlies the dorsal aspect of the distal radial ulnar joint. It's depicted here. As the video plays, you'll see the extensor digitorum or extensor digiti minimi move from a relative radial to a relative ulnar direction as it crosses the dorsum of the hand. Then lastly is the sixth compartment. Again, this is the extensor carpi ulnaris tendon. It's immediately overlying the ulna, depicted here. It will traverse across the wrist and then insert into the base of the fifth metacarpal. Here's the tendon in the little fossa on the ulna. Again, clinically, the first and sixth compartments are most clinically involved. Here's an example of Dequervain's tenosynovitis. The first top left image shows the abductor pollicis longus and extensor pollicis brevis tendons. You'll note that the overlying retinaculum here is easily seen, which usually means that it's abnormal. Often it's only about a millimeter in thickness. Often when it's abnormal, it will be quite thickened and readily apparent. Usually it's thicker over the extensor pollicis brevis tendon. Also note in this image that the cortex of the radius has a slight ridge in it. This usually delineates the fact that there is a subcompartmentalization of the two tendons. So the retinaculum here is overlying the abductor pollicis longus and then extends down to the radius, creating a subcompartment of the extensor pollicis brevis tendon. This is usually, again, associated with this ridge in the radius. Normally, if it was not subcompartmentalized, the radius would be flat here. As you see in the bottom left image, the tendon sheaths are devoid of any Doppler signal. This is not usually an inflammatory problem as much as it is a stenosing tenosynovitis issue. So the tendons are becoming entrapped by the overlying thickened retinaculum. This long axis image further accentuates the thickness of the extensor retinaculum overlying the tendons. This traps the tendons against the bone, creates irritation of the sheath, and then causes pain and sometimes triggering of the thumb. These can be injected. Classically, they're injected with corticosteroids. They can be injected either in plane with the transducer and the tendon coming from a distal to proximal direction or proximal to distal direction, depending on your preference, or out of plane relative to the tendons, but in plane with the transducer. The goal essentially is to place the corticosteroid solution within the sheath of both tendons, assuring that they are both treated adequately in case there is that subcompartmentalization occurring. The extensor carpi ulnaris can also be targeted easily. Typically, the forearm is pronated and the hand is flat on the table. Using a gel standoff window, again, the needle is brought in plane with the transducer but short access to the tendon. The solution would then be injected into the tendon sheath. As people become more advanced with their skills with ultrasound guided procedures and the technology advances, we're starting to broach into some surgical treatments for these disorders. So here's an example of a first dorsal compartment tendon release. The first top video here on the left shows anesthetic being delivered around the extensor retinaculum tendon here, filling the space around the retinaculum as well as the tendon sheaths. Then using this no-core needle, which is basically a hypodermic needle with a blade on the end of it, it is brought under direct sonographic guidance down into the retinaculum and used to cut the retinaculum, thereby releasing the compartment, which would be done with a surgical approach. This top right video here shows that the needle is being brought in directly or immediately overlying the compartment, ensuring proper placement in two planes while we're doing the procedure. The extensor carpi ulnaris, in addition to becoming entrapped or causing stenosing tenosynovitis, can also dislocate or sublux. This usually involves injury to the overlying retinaculum through a forced supination pronation maneuver, which may be seen with activities such as tennis. The patient would complain of painful snapping along the ulnar aspect of the distal forearm or wrist area. It's best or most easily evaluated with ultrasound by having the patient place their elbow on the table or examining surface. The forearm would then be facing the ultrasonographer or person performing the study. The tendon would be assessed in its short axis, and then having the patient either actively or you passively flex and extending the wrist, you could look for excursion or movement of the tendon out of the little groove or fovea here in the ulna in a volar direction. You should note that some subluxation or movement of the tendon out of the groove is normal. In fact, this study denotes that up to about 40% of the tendon may, in normal subjects or asymptomatic people, migrate out of the groove. So essentially you want to see the majority, if not all, of the tendon come out of the groove to call it abnormal. Here's a video displaying how that would look. This is a normal exam. As the flexion extension is occurring, you'll see the movement of the tendon, but it's not moving out of the fovea of the ulna. Moving a little bit more prox up along the forearm, there's a couple of other disorders referred to as intersection syndrome. These are more friction phenomena that occur between different tendon complexes as they overlap one another. The first one is in the distal forearm. It's where the first dorsal compartment would override the second dorsal compartment. This area can become painful in people that engage in activities such as rowing or weightlifting. This video might make it easier to understand what's happening here. Here you see the first dorsal compartment tendons overlying the second compartment tendons. Again, the first is the adductor pollicis longus and extensor pollicis brevis, coming over top of the extensor carpi radialis longus and brevis. This movement of the tendons, while normal in some people, can become painful, and they would report painful cracking or crepitus type sensation. Moving further down into the hand, as we saw earlier, the third compartment will move over top of the second. So again, the third compartment is extensor pollicis longus, and it's going to migrate from ulnar to radial over top of the extensor carpi radialis longus and brevis. Again, another area of potential friction and painful crepitus that may occur. Treatment for these could include ultrasound-guided injection. Typically, the corticosteroid solution would be placed between the involved tendon complexes. Mostly, we would come in from a radial aspect, moving ulnarly with the needle in plane with the transducer. The solution would be placed between the two tendon compartments. Moving further down along the dorsum of the finger, you can have injuries to the extensor tendon complex. At the DIP joint, you can have injury to the end of the tendon where it inserts into the base of the distal phalanx, such as may be seen with a ball striking the end of the finger, creating a mallet injury. It can involve injury to a tendon alone or a piece of bone, creating an avulsion fracture. This would lead to inability to fully extend the DIP joint. If the extensor tendon itself is injured along its central tendon portion here, then they may have the inability to fully extend at the PIP joint. If injury occurs to the dorsal hood, which is a retinacular structure that essentially envelops the MCP joint, where the extensor tendon is maintained in place, and then some of the intrinsic muscles and tendons are connecting into, if that structure is injured, it will allow these intrinsic muscles and tendons to migrate volar relative to the axis of the joint, and you'll get a boutonniere deformity, which is essentially hyperextension of the MCP joint, hyperflexion of the PIP joint, and hyperextension of the DIP joint. Here is a little bit more information on our dorsal hood injury. As you can see from this diagram on the left, this is the essential construct of this region. Dorsal would be on the top of the image, volar would be on the bottom. The ET stands for the extensor tendon, CT is connective tissue. This dark line here is the extensor hood. It has an ulnar sagittal band and a radial sagittal band. And as you see, it pretty much goes all the way down around to the volar side, connecting into the palmar plate on the volar side of the joint. Typically, the dorsal hood would be injured along this radial sagittal band, such as may be seen excuse me, with boxer's injury, where the flexed fist is struck against an object, thereby rupturing this radial sagittal band. This could then lead to instability of the extensor tendon, which would then migrate in an ulnar direction. So as the patient would flex their fingers, you would see the extensor tendon snap or migrate in an ulnar direction over the dorsum of the MCP joint, and this is often a painful process. Here's the sonographic image of that area. Again, you have the extensor tendon, the connective tissue here, and then the underlying metacarpal. This relative hypoechoic structure here is the ulnar sagittal band. Over here is the radial sagittal band. You'd be looking for injury along this region with migration of the extensor tendon in an ulnar direction if this was injured. This can be assessed dynamically. Typically, you need to use a large amount of standoff gel here to see these structures, as they are quite superficial, and some compression of the transducer may prevent subluxation of the tendon. So you want to use very light transducer pressure. Here, the tendon is being isometrically contracted, and it's tensioning the sagittal bands on either side, showing that they are intact. If they were not intact, then the tendon would migrate in an ulnar direction. Moving on to the superficial radial nerve, this can be injured as it becomes more superficial. As we know, it's a branch off the radial nerve at the level of the elbow. It then tracks underneath the brachioradialis muscle along the dorsum distal aspect of the forearm. It comes out between the brachioradialis tendon depicted here, as well as the extensor carpi radialis longus tendon here. We'll see in a video in a little bit, this nerve bundle here will come up through those two tendons. This is a potential entrapment site for the nerve and can cause painful neuropathic pain along the dorsum of the thumb and hand. As it becomes more superficial, it's also then prone to compression from external ligatures such as handcuffs or tight wristbands, etc., leading to chiralgia parasitica. This high-resolution video shows the nerve as migrating out into a more superficial location from underneath the brachioradialis tendon. Here you see multiple fascicles of the superficial radial nerve. I'll let it play a few times so that you can see it. So here's the brachioradialis tendon, extensor carpi radialis, longus tendon over here. As the nerve becomes more superficial, it's then going to migrate over the first dorsal compartment here, which is again the adductor pollicis longus and extensor pollicis brevis tendons. Along the dorsum of the hand, we also have the potential for accessory muscles. Usually this would present with an adolescent coming in with this non-painful gradually enlarging mass, creating some concern. The most common would be the extensor digitorum brevis manus, which occurs in about 2 to 3% of the population. As you can see from the diagram at the top right, it often either comes off the radius or a combination of the radius and ulna, usually inserting along the extensor digitorum communis along the index finger. It may have a single or have two muscle bellies and two separate tendons. If it is present, you should look at the other side because it can be present bilaterally in about a third to half. You would know that this is muscle by looking at the mass with ultrasound, where you would see in the long axis a normal pinnate pattern, and the short axis you see the normal starry night appearance. Additionally, dynamically, you would see the muscle contracting and getting enlarged or smaller, depending on which way the contraction is occurring. Moving on to the volar wrist, we'll look at the carpal tunnel, Guillen's canal, the wrist and finger flexors, talk about wrist ganglions, move on down to the fingers and talk about pulleys. There'll be a section on differentiating different types of tenosynovitis injuries, flexor tendon injuries, and then again wrapping up with some anomalous muscles and potential tumors around the hand. As we know, carpal tunnel syndrome is a very common problem in the population. The carpal tunnel is composed of a bony base with an overlying retinacular structure, the transverse carpal ligament. Within the tunnel, you have 9 tendons in the nerve, the median nerve. The 9 tendons are the 4 tendons of the FDS, 4 tendons of the FDP, and the flexor pollicis longus tendon. The entrance to the carpal tunnel is the tubercle of the scaphoid and the pisiform. So here's a sonographic image. The purple line here denotes the transverse carpal ligament. Here is the median nerve here in the center. The distal extent of the tunnel is the tubercle of the trapezium and the hook of the hamate. The dotted green line here is the rough location of the distal transverse carpal ligament. The distal aspect of the ligament is much thicker than it is volarly. Typically with ultrasound, we're asked to look at the carpal tunnel to see if someone has carpal tunnel syndrome. There's a variety of studies assessing this. Here are some of the common numbers that